Hey everyone, it's Dr. Frank Schaller. Welcome to lecture. We're going to start off today's lecture talking about respiratory. More specifically, let's talk about the chief complaint, cough. Here's a photo showing the anatomy of the thorax and lungs. It's important that you study the anatomy of the chest wall, identifying the structures as illustrated in this figure. I want you to note the number of the intercostal space between two ribs. It's the same number as the rib above it. Here's a view of the anterior ribs and the intercostal spaces. We do have a couple special landmarks on this anterior view. The second intercostal space is usually used for needle insertion for treatment of a tension pneumothorax. There's also the fourth intercostal space, which is most often used for chest tube insertion. And then finally T4 for the lower margin of an endotracheal tube seen on a chest x-ray. Finally, neurovascular structures run along the inferior margin of each rib, so needles and tubes should be placed just at the superior rib margins. And then, of course, we have the posterior ribs and intercostal spaces, as illustrated by this figure. I want you to note the T7 and T8 intercostal space. This is a landmark for thoracentesis with needle insertion. This is done just immediately superior to the eighth rib. Now we know that there are three right lung lobes in fissures, and the left side only has two. I want to point out this specifically because the right middle lobe here is often missed on assessment, on chest auscultation, and it is a fairly common spot to develop a pneumonia. So it does look like this right middle lobe is more anterior on the chest, so do pay good attention when you're auscultating breath sounds in this area. For example, an aspiration pneumonia is more common in the right middle and lower lobe because the right main bronchus is more vertical. So let's talk a little bit more about the chief complaint of cough. So cough is a common symptom that ranges in significance from trivial to ominous. Typically, cough is a reflex response to stimuli that irritate receptors in the larynx, the trachea, or even the large bronchi. These stimuli can include mucus, pus, blood, as well as external agents such as allergens, dust, foreign bodies, or even extremely hot or cold air. Other causes include inflammation of the respiratory mucosa, pneumonia, pulmonary edema, and compression of the bronchi or bronchioles from a tumor or enlarged peribronchial lymph nodes. Cough may also be cardiovascular in origin. Cough can signal left-sided heart failure. Some etiologies of cough include something simple like an acute nasopharyngitis. Most of those are going to be viral in nature, about 90% of them. There's also pneumonia, there's bronchitis, which again, bronchitis usually triggered by something viral in nature. Asthma, GERD or heartburn, and then there's also allergic rhinitis that you need to keep on the differential as well. A few other causes of cough could include things that are more rare, such as tuberculosis, maybe pulmonary embolism. Sometimes cancer can manifest as cough as well. So you want to keep all of these on your differential as you work through your patient. So defining the terms a little bit here about acute rhinosinusitis. Sometimes you'll hear rhinosinusitis, other times you'll hear nasosinusitis. They're essentially the same term. But talking a little bit more about this, so this is really inflammation of the mucosal lining of the nasal passages and paranasal sinuses, typically lasting up to about a month. It's caused by allergens, environmental irritants, and or infection. Most common etiology is viruses, but then again, there's bacteria, there's fungi as well. And then we have acute bacterial rhinosinusitis, which is different than acute rhinosinusitis. And it's different because it's usually caused by strep or secondary bacterial infection. And it's most common usually following a viral URI. It's relatively uncommon in adults and children. Less than 2% of viral URIs are complicated by acute bacterial rhinosinusitis. And in the majority, acute bacterial rhinosinusitis will resolve without any type of antimicrobial therapy. Then, of course, we have pneumonia, which is considered a lower respiratory tract disease. And the definition of a community-acquired pneumonia is infection of the lungs and bronchi caused by select pathogens acquired while residing in the community, not acquired while in the hospital or a long-term care facility. So let me give you a little case study here of what you might find when encountering pneumonia in your clinical setting. So we have Tom here. He's 38 years old. He's got no chronic health problems. He's presenting to your clinic with a chief complaint of a cough and feeling like he has a cold. He's not able to shake it for the past few weeks. He's also reporting an intermittent frontal headache. He's been taking Tylenol with mild relief, as well as having general malaise, and the cough is dry in nature. It's particularly problematic at night. He's denying nausea, vomiting, chills, fever, trouble breathing. He's not taken any antibiotics within the past year. He's allergic to penicillin with a hive form reaction. On your physical exam, you find that his pulse ox is 97% on room air, his blood pressure's 114 over 70, his temperature's 98 degrees Fahrenheit, his heart rate's 88, he's breathing about 20 times a minute, and you also notice on chest auscultation that he has bilateral coarse late inspiratory crackles without any type of wheeze. He doesn't appear in any acute distress. Chest x-ray is demonstrating, of course, bilateral interstitial infiltrates. This is something that you're going to see in clinic, fairly common. Generally, the treatment in this case for Tom, being previously healthy, you would use something like doxycycline, maybe a macrolide as well, such as azithromycin. If Tom had other comorbidities, whether it's COPD, diabetes, kidney or heart failure, amongst others, you may consider using a respiratory fluoroquinolone such as levofloxacin or maybe doxycycline plus a beta-lactam. Now, you might be wondering, in what setting would we treat Tom? Can Tom be treated at home? Does he have to come into the hospital? And one tool that you guys can use, and I would recommend memorizing either now or in the very near future, is the Curb 65. I know I saw a question on this on my nurse practitioner boards. There's a good chance you will as well, possibly a test question in this class as well. So, delving in a little bit further about Curb 65, it's used to calculate the location of appropriate treatment for a person with community associated pneumonia. Each item carries a weight of 1 point, and the higher the score, the greater the risk of community associated pneumonia associated mortality. Now, going through the Curb 65. So, the C in Curb stands for confusion of new onset. U stands for urea nitrogen greater than 7 or uremia. R stands for respiratory rate greater than 30 per minute. B stands for blood pressures less than 90 systolic or diastolic blood pressures less than 60. And then we have the 65 and Curb 65 just saying if their age is 65 or older, you're going to go ahead and give them 1 point. So after you have your results of the Curb 65 assessment, if their score is a 0 or a 1, you can go ahead and treat them as outpatient. If they're scoring a 2, I want you to consider a short stay in the hospital or watch very closely as an outpatient. And then finally, if you're getting a score of 3, maybe 4, maybe 5, this type of patient is going to require hospitalization with consideration as to whether the patient needs to be in the intensive care unit. Now, I do want to take a few moments here to talk about acute bronchitis. Could be another reason your patient is having a cough today. So, acute bronchitis is inflammation of the lower airways found in the absence of other airway diseases, such as asthma and COPD. And the vast majority, 90% of the likely causative pathogens, will be respiratory tract viruses, meaning no antibiotic is going to help this patient. In these patients, I want you to consider using something like Atrovent, an inhaled beta agonist like albuterol, or maybe you want to give them a short course of an oral corticosteroid such as prednisone 40 milligrams, PO daily, for 3 to 5 days. That's if they have a protracted, problematic cough. And then the other etiology of an acute bronchitis, 10% of these will be due to bacterial pathogens. And one of these could be pertussis in a non vaccinated patient. In these cases where you're suspecting a bacterial pathogen, I want you to consider the use of a macrolide or doxycycline when antimicrobial therapy is indicated.